Everyone. Today's class is on mediastinal masses. So mediastinum is a space in the thorax that lies in midline of the chest between the pleura of each lung and extends from the sternum to the vertebral column. Superiorly, it is continuous with the loose connective tissues of the neck. Anteriorly, it is limited by the chest wall. Laterally, it is limited by lungs and pleura. Posteriorly, by the thoracic spine, and inferiorly by the diaphragm. Divisions of mediastinum. There are four main classifications of the mediastinal divisions: anatomical classification, Sutton, Felsen, and ITMIG classification. Anatomical classification: the mediastinum is divided into superior and inferior mediastinum by the plane of Ludwig. Plane of Ludwig is an imaginary plane which is drawn from the manubriosternal junction to the T4 vertebral body. That is from here to here. That is a plane of Ludwig. It will divide the mediastinum into superior and inferior mediastinum. And the inferior mediastinum is further divided into anterior, middle, and posterior mediastinum. Anterior mediastinum is anterior to the pericardium. Middle mediastinum is within the pericardium. And posterior mediastinum is posterior to the pericardium. And next is the Sutton classification. It has anterior, middle, and posterior divisions. Anterior division is in front of the anterior pericardium and the trachea. Middle division is within the pericardial cavity and including the trachea. Posterior division lies behind the posterior pericardium and the trachea. So pericardium is the major landmark. Anterior to it, it is anterior division. Middle is within wherever the pericardial cavity is there, and posterior to the pericardium is a posterior division. Next is the Felsen classification. In that, anterior pericardium is from the sternum to the posterior aspect of the heart and the great vessels. In the other two classifications, heart was coming in the middle mediastinum. In Felsen classification, heart is coming in the anterior mediastinum. And the middle mediastinum is the compartment posterior to the heart and great vessels to a line drawn 1 centimeter posterior to the anterior edge of the thoracic vertebra. So this is the thoracic vertebra and it is the anterior edge. We have to draw a line 1 centimeter posterior to it. From that line to the posterior margin of the pericardium is the middle mediastinum. And posterior pericardium is a space behind the posterior limit of the middle mediastinum. Another classification is the ITMIG, that is the International Thymic Malignancy Interest Group. So it divides the mediastinum into prevascular compartment, visceral compartment, and paravertebral compartment. So prevascular compartment is the one colored in purple here. So it is anterior to the great vessels and the heart. Visceral compartment is where the trachea, great vessels, and the pericardium is. And paravertebral is where the thoracic vertebral body and the paravertebral soft tissues are present. So prevascular space contains thymus, fat, lymph nodes, and the left brachiocephalic vein. Visceral space contains the non-vascular structures like trachea, carina, esophagus, lymph nodes, and the vascular structures like heart, ascending aorta, aortic arch, descending aorta, superior vena cava, pulmonary arteries, and thoracic duct. And the paravertebral space contains the thoracic spine and the paravertebral soft tissues. Then mediastinal lines. We have the right and left paratracheal line, anterior and posterior junctional lines, right and left paravertebral lines, and the asagoesophageal line. These lines are more clearly taught in the previous class. So this is the anterior junctional line. The anterior junctional line will be seen little below the posterior junctional line. It is a point where the four layers of pleura meet anteriorly. So this is the anterior junctional line here. Here. This is where the point where the lungs meet and the pleura meet anteriorly. And in a chest X-ray, we can see the anterior junctional line here. So if there is an anterior mediastinal mass, that is a mass that may present here, it can obscure the anterior junctional line on the X-ray. And the posterior junctional line is seen slightly above the level of anterior junctional line in an X-ray because the lungs and the pleura meet posteriorly at an upper level. Here we can see the lungs and pleura are meeting at the level of trachea posteriorly, but anteriorly it was meeting after the trachea divided into the bronchi. Another thing that we have to know is the aortic knuckle and the pulmonary artery and the AP window. So the first convexity that we are seeing on the left is the aortic knuckle or the aortic knob, and the another convexity that we are seeing is a pulmonary artery or the pulmonary bay. The point in between these two, or the concavity, is the AP window. So in middle mediastinal masses like lymph nodes, this AP window is obliterated, or it will also become convex shaped. So approach to mediastinal masses. First, we have to localize it to the mediastinum. That is, we have to confirm that it's not a lung mass and it's a mediastinal mass. Then we have to localize it within the mediastinum into anterior, middle and posterior mediastinal masses. Then we have to characterize it with cross-sectional imaging. So these are few clues to locate the mass to the mediastinum. Mediastinal masses have smooth contour. They will create obtuse angle with the lung. They won't contain air bronchograms. They may be seen bilaterally, and the mediastinal lines will be disrupted. Whereas lung masses are surrounded by air, they abut the mediastinal surface and create acute angle with the lung. They may contain air bronchogram, and they will be present on one side only. So here we can see in the first image, this is a lesion, and it creates an acute angle with the lung parenchyma. Whereas the second image is producing an obtuse angle with the lung. So obtuse margins with the lung, disruption of mediastinal lines and absence of air bronchogram shows that it's a mediastinal mass, and acute margins will show that it's a pulmonary mass. So in the first image we can see there is a mass in the upper zone of the right lung, and we can see that this is the border of the mass. It is making an acute angle with the lung. And the second image, we are seeing an opacity in the lower zone, and this is the border of the mass, and it is making an obtuse angle with the lung. So the first image is a lung mass, and the second image is a mediastinal mass. So once we understood that it's a mediastinal mass, we have to now see if it's an anterior mediastinal, middle mediastinal or posterior mediastinal mass. So few signs that help us identify. One is hilum overlay sign. It is described by Benjamin Felsen. That is, if the hilar vessels are sharply delineated, it can be assumed that the overlying mass is anterior or posterior. That is, if there is a middle mediastinal mass, it will lie close to the hilar vessels and the vessels won't be seen clearly. But in case of anterior posterior, it can be seen clearly. That is a hilum overlay sign. So here we can see that in the first image we can see the hilar vessels properly here. So it's not a middle mediastinal mass. It is an anterior or posterior mediastinal mass. Second image also we can see the hilar vessels clearly here, and we have confirmed it with a CT thorax. That is an anterior mediastinal mass. Another sign is a hilum conversion sign. It is used to distinguish between a prominent hilum, which may be because of an enlarged pulmonary artery or because of a mass. If the branches of the pulmonary artery converge towards the central mass, it is an enlarged pulmonary artery. If the branches of pulmonary artery converge towards the heart rather than the mass, it's a mediastinal tumor. So here we can see that all these branches are converging towards this area. So this is due to the enlarged pulmonary artery. Instead, if you were seeing that all these branches are going like this, separate from this region, then it is a mediastinal tumor. Then obliteration of cardiophrenic angle. The cardiophrenic angle should have been seen clearly, but in case of anterior mediastinal masses, that angle will be obliterated, and in this case it is because of the epicardial fat pad. So obliteration of anterior junctional line, silhouette with right heart border and ascending aorta, hilum overlay sign, obliteration of cardiophrenic and retrosternal angle. These are all features that will suggest an anterior mediastinal mass. Anterior mediastinal mass include thymic lesions, lymphomas, germ cell tumors, and goiter. So we'll tell a few words about thymus. It's relatively large in infants. By 15 years of age, it is triangular in nearly all individuals. Marked lobularity of the thymus is always abnormal. In prepubertal children, thymus is homogeneous and the attenuation value is equal to that of skeletal muscle. In adolescents, it may be heterogeneous, containing areas of fat. So in the first image, we can see that the thymus is large and it's in a 3-month-old child. And after that, after 10 to 15 years, it will become triangular shaped and small. Thymic hyperplasia, it can be true or rebound hyperplasia and lymphoid hyperplasia. True or rebound hyperplasia is associated with chemotherapy, radiation, corticosteroid treatment. On CT, it will appear as diffuse enlargement of the thymus with preservation of the normal triangular shape. Definition of thymic hyperplasia is 50% increase in the volume of the thymus. And usually CT or PET cannot differentiate rebound hyperplasia from infiltration of thymus by a tumor. The only sequence which can differentiate is a chemical shift, where the thymic hyperplasia will have a loss of signal, whereas thymic tumor like thymoma won't have any loss of signal. And thymus usually returns to its normal size in case of thymic hyperplasia in 3 to 6 months. So there's a lesion. So we can see that the lesion is making an obtuse angle with the lung parenchyma. So this is a mediastinal lesion. Then now we have to see the anterior junctional line, posterior junctional lesion is more towards the lower zone. So those junction lines are not involved. Then we have to see the hilum. We can see the hilar vessels clearly here. So it's not a mediastinal mass. Then we have to see the cardiophrenic angle. The lesion is little above that level. So that is also not involved. Then we have to see the heart borders. The left heart border is clearly seen here, well demarcated here. But the right heart border at this point is not well demarcated. So it is obliterating the right heart border. So we have seen that when the heart border silhouette is lost, it is an anterior mediastinal mass. Then we can confirm it with a lateral X-ray where the retrosternal clear space is lost. So this is an anterior mediastinal mass, and we confirmed it with a HRCT thorax with contrast, where it was a fairly well-defined, well-circumscribed small lesion in the anterior mediastinum with few areas of necrosis and few areas of enhancement. So it was a right mediastinal contour abnormality that resulted in loss of silhouette of the upper right heart border, and the lesion is localized to prevascular mediastinum in the retrosternal space on the lateral chest radiograph. And on CECT, it was a well-defined solid moderately enhancing lesion with few non-enhancing necrotic areas. There was no bony erosion, chest wall involvement, anything. No infiltration of the adjacent structures were there. So these features were likely suggestive of a thymoma, a non-invasive thymoma in particular. So in thymoma, we have to know about the Masoka staging. There are 4 stages. Stage 1 is intact thymic capsule. Stage 2 is capsular invasion into adjacent mediastinal fat or pleura. Stage 3, macroscopic invasion into adjacent organs and vessels. Stage 4A and B are there. 4A is dissemination in the thoracic cavity, that is pleural or pericardial implants. 4B is distant metastasis. So this is another case. Here we can see there is a large mediastinal lesion and the right heart border is not clearly seen. So it's an anterior mediastinal tumor. And on CCT, it showed a large lesion in the mediastinum extending to the left hemithorax, causing mass effect on the left lung. Okay, we can also see that there is left pleural thickening here with some nodularity. So left pleural thickening is there with some nodularity here. So these are features of a large anterior mediastinal mass with pleural metastasis. So it was a case of invasive thymoma with pleural mets. There's another lesion of a well-defined hypodense non-enhancing lesion in the anterior mediastinum. It was a thymic cyst. So another lesion, a cystic lesion with few areas of enhancement. It was a case of a cystic thymoma. A very clear fat density lesion in the anterior mediastinum at the region of thymus, which was a thymolipoma. Another lesion with fat density areas are there, solid components are there, and multiple areas of calcification are there. So these were features of a germ cell tumor. And another fairly well-defined lesion, even being a little moderate sized, it is not causing any mass effect on the adjacent vessels or infiltrating the vessels. Instead, it is encasing the vessels. So these are features of a mediastinal lymphoma. So these were the few anterior mediastinal masses. Then we have to look at the middle mediastinal masses. So obliteration of paratracheal stripes, mass effect on the trachea, convex border of the AP window, and distortion of asagoesophageal recess. These are features of middle mediastinal mass. So we have seen in the previous image, the AP window should have been like this. Here the AP window has become convex. So this is a feature of a middle mediastinal mass, most commonly mediastinal lymphadenopathy. And here we can see that the right paratracheal stripe, this is the left one, right paratracheal stripe is not clearly seen. So this is also a feature of a middle mediastinal mass. And in CECT we can see that it's a right paratracheal lymphadenopathy. There are few pitfalls in the assessment of the middle mediastinum. Few of the normal vascular variants may be mistaken for the middle mediastinal disease at X-ray. Right-sided aortic arch is one of such causes, and left-sided SVC. So here we can see in the first image there is a right-sided aortic arch, but it is looking like there is loss of the right paratracheal stripe. It's looking like a mediastinal mass on the X-ray. And in the second image we can see there is left-sided SVC, and that is also looking like a mediastinal mass. There is mediastinal widening in the X-ray. Few differential diagnoses for middle mediastinal masses include lymphadenopathy, aneurysms, congenital like pericardial foregut duplication and pericardial tumors, cardiac tumors, neurogenic tumor from vagal or phrenic nerves, and esophageal masses, example leiomyoma, esophageal cancer, hiatus hernia. And now posterior mediastinal mass, distortion of paraspinal lines, posterior ribs or vertebral erosion, cervicothoracic sign, obliteration of posterior junctional line and descending aorta, and distortion of esophageal recess are signs that tell that it can be a posterior mediastinal mass. So cervicothoracic sign, when the cephalic border of a mass is obscured at or below the level of clavicle, it is deemed to be a cervicothoracic lesion involving the anterior mediastinum. So we can see in the first image that posteriorly the mediastinum is extending at a superior level than the anterior mediastinum. So if a lesion is extending above the level of clavicle and we are seeing the upper level of the upper border of the lesion clearly, it is most likely to be a posterior mediastinal lesion than an anterior mediastinal lesion. That is a cervicothoracic sign. So in the first image, we are seeing a lesion here, but we are not seeing the borders of the lesion above the level of clavicle. Rather, in the second image, we can see a lesion here and we can see a clear border above the level of clavicle. So the first lesion is an anterior mediastinal lesion and the second lesion is a posterior mediastinal lesion. That's what a cervicothoracic sign. Another thing in posterior mediastinal mass is distortion of the left paravertebral line. So we can see this is the right paravertebral line, it's clearly seen, but the left is distorted by a lesion here, and it is confirmed by CT, which is a left paravertebral mass. It's a posterior mediastinal mass. Then another sign is thoraco-abdominal sign. Like superiorly, inferiorly also the posterior mediastinum is extending to a more inferior level than the anterior mediastinum. So if any lesion is extending below the level of the diaphragm, then it is more likely to be a posterior mediastinal mass rather than an anterior mediastinal mass. So here we can see that the right paravertebral line is clearly seen here, but we are not able to see the left paravertebral line. So there is a hidden mass here along the left paravertebral, so it's a posterior mediastinal lesion. And on CT, it was a lesion which has which is in close contact with the neural foramina, and it came out to be a neurogenic tumor, schwannoma. So other differentials for posterior mediastinal masses are nerve sheath tumors, aortic aneurysm, paraspinal hematoma, sympathetic ganglion tumor, which is neuroblastoma when it's younger than 3 age, ganglion neuroblastoma 3 to 10 years, ganglion neuroma older than 10 years, and paraganglioma, paraspinal abscess, lateral meningocele, extramedullary hematopoiesis, and esophageal duplication cyst. Here also we can see that the left paravertebral line is obliterated, and on CT we can see there is a paraspinal abscess effacing the paraspinal lines. And extramedullary hematopoiesis, we can see bilaterally there are multiple areas of mediastinal lesions which is in bilateral paravertebral lines and effacing bilateral paravertebral margins. This is seen in extramedullary hematopoiesis, and the first X-ray we can see that the ribs are also little lytic areas are there on bilateral ribs. Thank you. So rather than knowing the imaging features of all the masses, it is very important to identify if it's a lung mass or a mediastinal mass, and also to identify if it's in the anterior mediastinum, middle mediastinum, or posterior mediastinum. Thank you.